Is everybody with me? The first reason you need to know about the beta-lactam ring is because of allergies, and now I think you got it. But the second big reason you have to know about that beta-lactam ring is because of an enzyme called beta-lactamase. Beta-lactamase is an enzyme that smart bacteria learn how to make. Why smart bacteria? Because the goal of a bacterium when it wakes up every morning is always the same goal. I want to live another day. I'll do anything to live another day, including learning how to make beta-lactamase. So listen to this. If you're a bacterium, you probably are a little paranoid because somebody is always trying to kill you with an antibiotic. So imagine being a bacterium. So you want to live another day. You don't want to die today. You learn how to make this enzyme called beta-lactamase because if somebody tries to kill you and they try to jump penicillin on you, all you have to do, smart bacterium, is look, squirt out your beta-lactamase. Because when your beta-lactamase hits the beta-lactam ring in the penicillin molecule, that ring will collapse. Penicillin can't kill you, and you get to live another day. If you're a bacterium and you know how to make beta-lactamase, and somebody tries to kill you by dumping a cephalosporin on you, look, all you have to do is look, squirt out your beta-lactamase. When it hits the beta-lactam ring of the cephalosporin molecule, that beta-lactam ring collapses. And the cephalosporin can't kill you, and you get to live another day. So here's what you ought to be thinking. You ought to be thinking, wow, when a bacterium knows how to make beta-lactamase, oh man, they're a whole lot harder to kill. In fact, they're a whole lot harder to kill. So some smart chemist said, hey, wait a minute. I cannot believe that these little unicellular organisms are going to outsmart us. I have an idea. And this is what the smart chemist did. They took amoxicillin and they covered the beta-lactam ring. They protected it. And when they did that, bacteria that squirt out beta-lactamase hit the cover on the ring. It couldn't hit the ring. And the antibiotic killed the bacteria. What's the name of that antibiotic? Augmentin. Augmentin is nothing but amoxicillin with its beta-lactam ring protected. And if the ring is protected, the antibiotic will kill an organism that knows how to squirt out beta-lactamase. Everybody with me? All right, so that's why it's so darn important to know about the beta-lactam ring. Because of allergies and because of resistance. Resistance specifically with beta-lactamase. Quick review, you ready? I want to know, gram positive or gram negative? MRSA, positive because it's staph. MSSA, gram positive. And what about, we talked about this morning, drug-resistant strep, pneumo, gram positive. All right, y'all got it. You ready? If you have those antibiotic cards, you can pull them out. If you don't, the information is in your book. It's just not colored and so pretty, all right? So let's start out with the penicillins because those were the very first antibiotics ever. They were discovered by Alexander Fleming, and he grew them on a petri dish, and it was a mold. So one of the reasons so many people were allergic to penicillin early on is because they were allergic to molds. And so if you were allergic to molds and you got Alexander Fleming's penicillin to grow in a petri dish, you would have an allergic reaction to it. Today, that's impossible, simply because we don't grow penicillin in a mold anymore. It's grown through recombinant or developed through recombinant DNA, and so it doesn't matter if you're allergic to mold or not. Penicillin comes in many different forms. Plain old penicillin that probably every one of us in this room got at least once are things like ampicillin, amoxicillin, PenVK, penicillin G. Why on earth would you give a patient amoxicillin? Why would you give them a plain old penicillin? Because you thought they were infected with a gram-positive bug. Now there's a little invisible asterisk. You see it right here? You see the invisible asterisk? Okay. If you told me you see it, If you didn't see it, All right, so listen. Gram-positives, that's why it kills gram-positive bugs, but not staph. So if a patient has a staph infection, you don't give them amoxicillin. But it does kill strep. Hey, wait a minute, Amelie. Is that a typo? Look, it said a drug like amoxicillin could kill drug-resistant strep pneumo. Is that a typo? That's not a typo at all. It really can kill it. And you would know that if you had ever written a prescription for Augmentin XR. How do you dose that drug? You give Augmentin XR 2 tabs in the AM and 2 tabs in the PM. That's how the drug is supposed to be prescribed. You know how much amoxicillin is in one tablet? 1,000 milligrams. When you take 2 tablets in the AM, you get 2,000 milligrams of amoxicillin. So what dose is it for adults that kills DRSP? It's 2,000 milligrams in the AM of amox, 2,000 milligrams of amox in the PM. You got it? So high-dose amoxicillin kills drug-resistant strep pneumo. Is it my first choice for pneumonia? No. But if I couldn't give somebody a quinolone, like a respiratory quinolone, or they couldn't afford it, or they had QT interval prolongation problems, amox might be a good way to go. What about in kids? We use that all the time because we don't give kids respiratory quinolones. We use it for otitis media in kids. We give 90 mg per kg per day. We use a 90 mg per kg per day dose for community-acquired pneumonia in kids when it's strep pneumo. So that's a dose that we use. But to be honest with you, it's something that a lot of people just don't think about. But giving it in high enough doses certainly will eradicate DRSP. All right? So let's keep going. Plain old penicillin, we just talked about them. When they cover the beta-lactam ring, it produced an antibiotic called Augmentin, and all of Augmentin's generics. When we give a patient Augmentin, this is a bug, or these are the bugs you expect to kill. Those that know how to squirt out beta-lactamase. Why? Because the beta-lactam ring is covered. And because amoxicillin is this antibiotic, we expect it to kill gram-positive bugs. But you know what else happened when they covered the beta-lactam ring? We picked up coverage of a bunch of gram-negative pathogens. So when you give a patient Augmentin, what you are telling me is, I don't know what they have. It kills gram-positives, gram-negatives, and beta-lactamase producers. So this is a good antibiotic, but to be honest with you, it doesn't cover MRSA. So you might be sitting there having this question. In fact, I hope this is a question you're having. All right, Amelie, I get it. I get the whole idea about the little bug being smart, knows how to make beta-lactamase, squirts out the enzyme, and it kills the beta-lactam ring. I get that. How on earth would I know a bug knew how to do that? How would you know? It's simple. You always suspect that a bug knows how to make beta-lactamase if the patient has had an antibiotic in the last 3 months. If the patient has had an antibiotic in the last 90 days and they're sick again today, you don't give them amoxicillin. You suspect that the patient has a bug that squirts out beta-lactamase. And if that's the case, you have to step up your treatment and give them something like an Augmentin. Everybody with me? I'm changing gears and we're changing drug classes. I'm going to talk about the sulfonamides, of which you know these two drug representatives as Bactrim and Septra. And I'll bet you the first time you ever gave or got Bactrim was for UTI, because gram-negative pathogens were why we gave Bactrim and Septra all the time. We use them to treat E. coli, most famous pathogen that causes urinary tract infections. But Bactrim's real use today is in treatment of patients who have wet skin problem. MRSA, right? Great choice. So listen. You might be looking at this and thinking, hey, wait, Amelie, Bactrim, yeah, I know we use that for MRSA all the time. Well, is this a typo? We don't use it for E. coli? You mean like a urinary tract pathogen? If you know Sanford Guide, the Bible of antibiotics, Bactrim is not a good choice anymore to treat urinary tract infections secondary to E. coli. How come? There's a greater than 20% resistance rate. So a good first choice is no longer Bactrim when you're trying to treat UTIs, unless you have a culture and sensitivity report in hand that says this is the one that'll work. The other reason you don't do it is because you want to save Bactrim to treat MRSA. that people walk in with all the time. The last point I want to make about this is this one. If we use Bactrim to treat maybe gram-negative infections, do you realize why we would never use Bactrim to treat strep throat? Strep is gram-positive, and this doesn't kill gram-positive bugs. You with me? So we don't use Bactrim for strep throat. That's exactly why we don't. What about the tetracyclines, another drug class? It's an old one, and I know you've prescribed doxy or minocycline or vibromycin. Those are common examples of tetracyclines. Why do we give patients that? We give it to them when we think they might have a gram-negative infection, but we also use the tetracyclines to treat MRSA. Wait, Amelie, we use Bactrim all the time. Yeah, keep doing that. But what are you going to give a patient with a MRSA infection who's sulfa-allergic? You now have a great second choice in a tetracycline. What are you going to give a patient who's got community-acquired MRSA who got Bactrim 4 weeks ago and now they got MRSA again? You know you're not going back with Bactrim, but you need an alternative, and that might be a good one. This morning when we talked about atypical pneumonia, you remember what your two options were for treatment? A macrolide or doxycycline. Why do we use doxycycline? Because it treats atypical pathogens. Do you see why we would never use doxycycline to treat strep throat? Because strep is gram-positive, and this doesn't cover the gram-positive pathogens. You follow me? All right, let's keep going. Suppose somebody comes in and says, Amelie, I'm panallergic. What question is supposed to just roll off your tongue? What kind of reaction did you have? Suppose they say, well, I don't know what kind of reaction it was, but when I woke up in the ER, my tongue was swollen out of my mouth. Anybody want to give them a cephalosporin? No. Not even on your luckiest day, right? Suppose somebody says, Amelie, I'm panallergic. What kind of reaction did you have? I don't really know what kind of reaction it was, but I had these things all over me. They looked like silver dollars. They were all over my skin. They were raised red and highly puritic. The patient probably wouldn't say that. Oh, it's highly puritic. What, would you give a cephalosporin? No, because they're describing hives. Suppose they said, Amelie, I'm allergic to penicillin. What kind of reaction did you have? I don't know what kind of reaction it was. I had a rash everywhere. They gave me penicillin because they thought it was strep throat, and then they found out I had mono. Would you give a cephalosporin? Of course. Let's talk about the cephalosporins. They're delicious. They are. They're delicious. If you got to give a drug to a kid, they love cephalosporins. The other thing is that they're well tolerated in adults and they're easy to take. So let's take a look. These were divided into generations. The first generation cephalosporins are drugs that we use to treat skin and skin structure infections. You know those two antibiotics. What are they? Keflex and Duracef. So those are the first generation cephalosporins. They kill gram-positive pathogens like staph, and staph is implicated in skin infections, and you see why we use these for skin and skin structure infections. Exactly. So those work great. People loved them. But prescribers asked the smart chemists to give a cephalosporin that could kill more bugs than just gram-positive ones. So the chemists went back to work. And I want you to look at this. This is a chemical structure of a cephalosporin. Look, here's the blue box, and here's the orange hexagon. This is exactly what a first-generation cephalosporin looks like. To get a second-generation cephalosporin, what the smart chemist did was take the orange hexagon and swing the ring around. And when they did that, they produced a whole different class of antibiotics called second-generation cephalosporins. Look at what drugs those are. Ceftin, Ceclor, Cefzil. Why would you give a patient one of those? Well, you know what happened when they swung the ring around? They picked up coverage of gram-negatives. So now if you're not real sure what infection a patient's got, heck, it could be gram-positive, might be gram-negative, I don't know. You can give one of these antibiotics. Good choice. Kills gram-positives and gram-negatives. But let me ask you something. Do the second-generation cephalosporins kill beta-lactamase producers? Nope. So if somebody said, hey, Amelie, I had a sinus infection 6 weeks ago, treated with amoxicillin, I completely cleared. 6 weeks later is today. They have another sinus infection. Would I ever give a second-generation cephalosporin? No. Why not? Because the bud making them sick today is probably one that knows how to make beta-lactamase, and the second-generation cephalosporins can't kill beta-lactamase producers. Well, prescribers said, smart chemists, can't you please go back to work? Can't you please give us a cephalosporin that kills beta-lactamase producers? And so the chemists went back to work. So look, here's the blue box, the beta-lactam ring. Here's the orange hexagon, and this is a second-generation cephalosporin. The smart chemists took the orange hexagon and swung the ring completely around. And when they did that, they created third-generation cephalosporins. Let me show you what drugs those are. They're drugs like Cedax and Suprax. When the smart chemists swung that orange hexagon around, you know what happened? They picked up coverage of organisms that knew how to make beta-lactamase, but something they didn't want to happen happened. They lost coverage of some of the gram-positive pathogens. So smart chemists, let me ask you a question. If a patient had strep throat, would you rather give a second or a third-generation cephalosporin? Second every day of the week because it's got better gram-positive coverage and strep is gram-positive. Suppose a patient had a sinus infection 6 weeks ago. 6 weeks later is today, they have another sinus infection. Would you rather give a second or a third-generation cephalosporin? Third every day of the week. Well, prescribers said, wow, smart chemists, y'all did a great job. But we hate that we lost our gram-positive coverage. Can you help us? And so they did. They took the chemical structure of a third-generation cephalosporin and they tweaked the ring just a little bit. They tweaked it, and when they did that, they picked up gram-positive coverage. We call those extended spectrum third generations. You know these drugs. That's what Rocephin is. When do you give a patient Rocephin? When they're very sick and you don't know what they have, right? That's what you do. Why? Because look, it kills gram-positives, gram-negatives, and the beta-lactamase producers. So that's why they get it. When you give an injection like Rocephin, you have to follow up with an oral that has the same antimicrobial spectrum. You don't go give them amoxicillin. You give them one of these, something like Omnicef. You get it? So that's why, and that's a strategy you use when you go after those bugs.